Hi, Jana. How are you today?
Very good. Exciting news. I think everybody would be happy to hear this. Shiloh had her first dental appointment, and it was like a dream. I mean, I've never seen anything more perfect in my life. It was amazing. So,
Awesome. That's
Good
got to be a
day.
weight off, right? Getting that over
Good
with
day.
and it went well.
Yeah.
So she'll have a lifelong healthy relationship with dental care. That's wonderful.
Yeah. It was really great to see. So,
Chad Teeters, as I live and breathe.
What's happening?
Hey, boss. What's going on?
Living the dream. Part of being a rock star.
Hey, Jana, on your end, does it look like Dr. Topa keeps trying to get in, but he keeps popping up in my waiting room, and I keep
No,
okay.
well, actually, just as you said that, no, he's in here.
Okay. Because he's on my end, he looks like he's in the, okay. Yeah, I just saw his text. Weird. Okay.
Don't see Dr. Shipley yet.
She's coming in right now.
Oh, perfect. There she is.
Miss America.
That's right. Crown and all.
I'm sorry, Dr. Miss America.
Oh, yeah, let's get the titles right. That'd be Dr. Ms. America.
I'll just go with Dr. America. That'd be pretty sweet.
Dr. America. Yeah, there we go.
Sounds like a new Marvel comic.
Yeah.
Yeah, it really does. It's kind of frightening. Let's change the subject.
All right, we'll give everybody another couple seconds and then we'll get rolling. As an aside, while everybody's gathering, has anyone ever, for any purpose, ever logged onto the internet and used this Angie, ANGI, to like search for like it's supposed to be like one of those like Yelp for service kind of contractors. So I was looking, okay. So it's supposed to be like that, kind of find people who are recommended who do service in your area. And I needed like a plumber. So it wasn't like rocket science kind of thing. Well, whoever Angie is, Angie now is my best friend in the world. And she sends me emails 7,000 times a day of like, how about housekeeping? How about washing your car? Can I plant some tulips for you? I'm like,
Oh,
I don't
Angie's List. Only now it's Angie. Yeah, Brent was a big Angie's List.
Oh
person.
my God. I can't get away from Angie. Like she haunts me in my dreams. Like she's never going to go away now. I think we put Angie on COVID and it'll be gone by tomorrow. Everything will be fine. No
Oh,
more.
good. Fantastic.
All right. So why don't we go ahead and get started before Angie shows up and gets mad at me. So welcome back, everyone. I hope everyone had a lovely Thanksgiving where you tied a plastic bag around yourself and hid from family and friends because it's not so great out there right now, to say the least. So lots of things to catch up on today, several developments, both in the medication side, obviously booster discussions, and then obviously the big conversation is Omicron and what does this mean for us? So the first, I get this a lot. Is it Omicron or is it Omicron? And as a classic major, I actually do appreciate that question. So it's either, it's whatever your heart desires. That's the first answer. So you can go either way. No one really knows which way the ancient Greeks preferred, but Omicron seems to carry the day most of the time. So take with that what you will. So lots of press that I think is actually making this harder in the short term, quite honestly. So at this moment, we still do not have cases in New York State. I'm not aware of any cases in the United States. We do know that across Europe, there are cases in Canada. Every anticipation is that it probably is here. Interestingly, even though the discussion is that it was first found in South Africa, the reality is that last night there were cases, I think, in Amsterdam that were sequenced as far back as November that actually seemed to be consistent with the Omicron strain. So this, again, much like what we saw with Delta, probably has been circulating without our knowledge for some time. And just because it was first found in South Africa, A, doesn't matter, B, doesn't really have any particular significance, but it obviously has raised a lot of questions about what's the value of travel bans. If we're placing travel bans, shouldn't we just be doing this worldwide? And I think that's why we're hearing a lot from the CDC to go back to more ubiquitous testing for people coming in, whether it's citizens or foreign nationals from anywhere in the world. But realistically, much like we saw with Delta, once we get cases reported in the US, it's going to be just as prevalent in the US, if not more than it is anywhere else. So that's the first piece. Number two, and perhaps the most important part about this at the moment, is everything that we know about it thus far, which still isn't a tremendous amount, suggests that it is likely highly transmissible, as is the Delta strain. However, it does not, at least in the early phase from the data out of South Africa, it does not necessarily seem to be causing more severe disease or even more hospitalizable disease than the Delta strain. And in fact, the vice chair of the South African Medical Association, I think it was last night, came out and said, this is getting a little bit blown out of proportion of what we're experiencing, that the most common side effect that they're seeing with Omicron, interestingly, is not loss of taste and smell, not even as much respiratory, as much as it is profound fatigue. And that 90% of the cases that have been hospitalized in South Africa have been amongst the unvaccinated population. So that's a key, because one of the big things that continually gets asked is, are the vaccines effective against Omicron? We don't know for sure at this moment, but the propensity of evidence, at least out of South Africa, in the endemic areas, suggests that this is predominantly in a younger and unvaccinated population. So I do think that lends some credence to the fact that this probably does not evade vaccines completely. And in fact, our own CDC folks in the US have said it would be unreasonable to suspect that it would be completely immune to the existent vaccines that we have, no pun intended. So all that's a way of saying it's important. It's yet another strain. It raises the question of boosters. And so a couple folks have reached out and said, should we be advising patients to wait now that there's discussion of development of an Omicron specific booster? I think the clear and abiding answer to that right now is no. There is no data that says they should wait. And in fact, the propensity of data that I can see at this moment would say getting a booster is far better, because Delta is still the prevalent strain. And we know there's the concern about waning immunity for those who got vaccinated more than 8-9 months ago. And there is some suggestion that there may actually be some beneficial effects of being vaccinated, even though it's not an Omicron specific booster dose. So, I didn't realize, people have kind of jokingly said, does this mean there's going to be a fourth booster? I think there was something, I think it was out of Canada before Omicron became a thing, that some Canadian health minister had said that the anticipation was that there would likely be 5 to 6 total shots, like with extra boosters, before we started doing kind of the routine yearly vaccination like we do with flu. I don't even know how we would begin to estimate that at this point, quite honestly. But I think 2 things remain to be pretty clear. Number one, making sure that people are A, vaccinated, and B, getting boosters does seem to be the most beneficial step at this moment. And 2, as we look worldwide, from the pandemic standpoint, getting vaccines to the entire world, not just the more wealthy nations, is going to be the biggest way that we can stop these endemic subvariants from catching on and then spreading over and over again. So I do think there's more and more effort and thought process in that. I mean, I think, you know, from a purely holistic standpoint, this is probably better than most other drugs in the world, but obviously there's a lot to do to get us back to the life that we all know and love. So that's what I would say, you know, is I'm by no means am I a specialist on this, but that's from everything I can read on Omicron, that seems to be the state of the union. We do anticipate, I think pretty much every large institution, most of the sequencing labs are working feverishly to now sequence for Omicron across the country. So I'm sure in the coming days, we will likely start to hear about Omicron cases amongst the positive in the US. We just haven't heard that yet. And then shortly thereafter, I think all of the vaccine companies are both looking to see what the efficacy is of their vaccine against Omicron, and they're already working on potential Omicron boosters because it takes about 30 days for them to generate a new booster, and then about another 60 days to test it and have it ready to go in the population. So theoretically, in as little as about 90 to 100 days, they could have an Omicron booster ready if it was so necessary. But that remains to be seen at this moment. For the other boosters, you know, lots of discussions on two realms. Number one, for the immunocompromised who were advised to get a third dose, do those folks need to get a fourth dose booster? My understanding of this, and folks feel free to correct me if I'm wrong, because I can't say that I found any clear and convincing evidence at this point, was that the third dose was really meant to get them up to snuff of what most of us would get after the second dose, whereas the fourth dose booster may be the necessity to get them the same effects that a third dose booster would be in an immunocompetent individual. From the data I've read, it would say that after that third dose, you probably wouldn't need to get the booster for at least another 6 months. So it basically just extends the timeline. Their third dose is our second dose kind of situation. But that, I don't think there's any hard and fast recommendations to this point. All of us know, you know, if you want to get a booster, pretty much you can walk into any CVS and Walgreens and say, I'm a candidate and need it. So I don't think there's any huge bar that you have to cross. But for folks who have immunocompromised individuals who did get a third dose, who are now wondering, do they also need a booster? The data that I've seen so far suggests that that may actually be beneficial, but it will be at least 6 months after that third dose. We've got time to play that out and see what the recommendations are going to suggest. The other question that continues to come up, and which I would say at this moment we still don't have great data to suggest it's warranted, is should we be doing the heterologous booster? So if, for instance, if you got Pfizer as your first dose, should you get Moderna or Johnson & Johnson for your second, and vice versa? The answer right now, the early data would say it's probably not, does not matter. There was a very small amount of data that suggested very early on that a Pfizer Moderna booster may have had the best effect, and that potentially having COVID and then getting a vaccine was even more pronounced in its antibody response. But as I think we talked about here before, the infectious disease folks and the folks who have been involved in the vaccine generation have largely said the preponderance of data says it is beneficial that you get a booster, not which booster that you get. So for right now, it's more just important to get a booster. I know some people have said, you know, they've got patients who are looking for this particular type booster. Obviously, if that's the difference maker between them being willing to get a booster, I would say it's worth the effort. But right now, I would say the science is just get a booster. There's not a particular sequence or booster that you should be seeking out, I think would be the best evidence that I've seen so far. The final piece of update in therapeutics, one is monoclonal antibodies. So there's been a few people who have reached out because of concerns of the U of R in particular ratcheting down their monoclonal antibody administration. So that is not due to a lack of belief in the benefit. It is more due to a lack of staffing with a surge in need for hospital staffing with the patient volumes increasing to unprecedented levels. So the question then becomes, where can my patient get monoclonal antibodies, and can we administer monoclonal antibodies? So I have been told that yes, private practices would be able to administer monoclonal antibodies. I am still awaiting, I'm hoping today to get information on exactly how, if you are interested and so plan to do so, how you would go about ordering that for your practice. And then I've also reached out to the primary care network because they've already developed their own plan. They've been administering monoclonal antibodies in several of their practices now for a couple of months. And so if folks need a workflow or a protocol, they seem to have a pretty good sequence that they've been working off of that's working well for them, that hopefully I can just get and then share with all of you for your own use. And look at that. Ta-da!
We actually do have this and it's up on our website. And I will throw the URL up into a screen to show everyone. But this came out in September. There is guidance on how to order the whole process. So we have that, Chad.
And actually, if somebody can chime in, because somebody told me that this didn't work.
Okay.
So if that's the case, I can't remember who told me that. If somebody can chime in and say that now, because I haven't tried it myself, I'll readily concede. So I did reach out to our pharmacy team just to see if there was a new process. But yes, I do remember us putting this up, and to my knowledge, it hadn't changed, but somebody told me that they tried and that this didn't work. So one way or the other, I will find out if there's new and improved information, and we will share it with you. So yes, thank you very much. Some more to come on that, both with the protocols, if folks want to borrow that, and then number two, if there is any updated guidance, we will pass that along. The next thing that a few folks have reached out, and I just don't have good information so far because it's fairly fresh, is the FDA approval of the Merck antiviral drug. So in the most naive and simplistic way possible, I am kind of thinking of this as Tamiflu for COVID, for lack of a better explanation. So it is a 5-day course. I will say it was approved with a fairly narrow margin by the FDA under the emergency use authorization. But the anticipation is that it should be fairly readily available in short order. And supposedly Merck in particular, I think, was generating something like 18 million doses to have available if and when the EUA was approved. So I have not heard anything as of yet that it is available in pharmacies to begin prescribing. I've also not heard that it is being cohorted through state or federal government. So I do believe it will be able to be prescribed as per normal medications. What I don't know as of yet is, normally these medications would have to be reviewed by the payer to see what the coverage is. So more to come on all that. I think there's a lot of details still to be worked out because the approval just came through yesterday around lunchtime, if I'm not mistaken. So as soon as I hear more about that or we learn more, we can definitely share that with you, just so you got it. So I think that's all for that. The other question, a couple of folks have reached out asking if they have a patient who is positive, can they request sequencing for that particular patient? The answer to that is no. So there is no COVID sequencing order. It's being done as a routine screen of a percentage of all positive tests right now. But there is no way that you can specify that I want my test or my particular positive patient subtyped. So I just wanted to answer that because a couple folks had asked that question, and that is not a routine order that can be done. I think that's all I have for my updates. I will turn it over to LJ for hers.
Thanks, Chad. I just have a few things. Just as a reminder, there is a pediatric PCP advisory committee meeting tonight for our peds and family medicine practices and representatives. We're going to go into more detail around questions you may have or any sort of looming changes to any of the guidance around testing and return to schools and return to schools, return to play and all that sort of stuff tonight. A couple of things are still being finalized in that space. So please do attend. And if you're unable to attend and you're a normal representative for that group, see if you can have someone else from your practice attend in your stead. That would be really helpful. Just wanted to say again, a big shout out to all of you who are vaccinating, to all of you who are vaccinating everyone with COVID vaccine, but a special shout out to those who've been working in the space for the 5 to 11-year-olds, according to information that is coming out through NICES as of last week, November 25th, we had passed we had hit 18.4% of children aged 5 to 11 being vaccinated in the Finger Lakes region. That equates to nearly 18,000 children being vaccinated in that age group. And then 12,000, almost 13,000 of those are within Monroe County. And so the rates within Monroe County are at 21.2% and rising. I think, again, it's a tribute to all of you who are working so hard within your practices to do this, as well as to some of the centralized efforts with the counties in the region. Just to remind you, if you are in a space where you have more families wanting vaccine than capacity and want to be able to refer, the Golisano Children's Hospital vaccine site at La Chase, which is down in the medical school end, is now open to the public. They are accepting walk-ins. There's an open link. We can put the information into the messaging that goes out this week, just so you have that. And Monroe County obviously is doing their centralized sites both within the city and then on the west and the east side, just to assure that people have as much accessibility as possible. We're connecting with all of you regionally just to see what is happening in your own practice or in your own county. And we will continue to connect with you about ways that your efforts may be supported. It's really, really important that we continue to push forward on this. I think as more children are vaccinated and as our rates are rising, it is more likely that families who may have been on the fence or waiting a little bit will be inclined to want to vaccinate their kids. So we want to make sure that accessibility remains for them. I wanted to pivot for just a second and talk for a moment about the email we sent out on the 23rd, which had to do with some of the new programs within the schools within Monroe County and outlying counties around Test to Stay. Just to be very, very clear that this is a program that allows students who are unvaccinated and are quarantined to be able to continue to participate in school if they're asymptomatic. And it's through daily testing that's done in the schools. It is not our understanding that most schools are allowing any kind of testing from home. They're trying to implement this themselves. If you have questions about that, we can certainly review anything in that space. And then I think that the other piece that I just wanted to highlight is there is some confusion right now, and nobody's more confused than I am, actually, about the fact that there's New York State guidance around what happens for children or students who have symptoms post-vaccination that is not in direct alignment with what Monroe County guidance has been. And I'm going to just have to say to you that stay tuned, because I've reached out to the county several times this morning to have them clarify if they're shifting to New York State guidance. There's some real differences in there, which includes allowing antigen testing in the state guidance for symptomatic patients, and that's not been standard of care. So I ask people just to, from the best of my knowledge, we are still holding with Monroe County guidance at this point and have not shifted over. And if we do, and if they have, I will let you know. It's not something that's gone through the schools reopening task force or any other space at this point yet. So I think that the only other thing I wanted to let our practitioners know from a resource standpoint, I know that testing supplies for point of care PCR remains limited, that some of you are getting some supplies, but they're in very small quantities and not consistent, and that the volume of patients requiring testing continues to go up. Monroe County Department of Health, as well as some of the outlying counties, are providing rapid testing options that will continue going forward. I know you're aware of that. The Golisano Children's Hospital pediatric site that is located in White Spruce Boulevard still prefers to receive referrals. But I know that that has been an issue for many of our practitioners in the primary care practices, that they really have not felt comfortable doing a referral for just the PCR, which is not rapid PCR, but it is PCR that's being turned around in about 24 hours. That site will now take patients without referral as well. They're increasing their capacity to do so. So I wanted to let people know that that is an option. Some of you have reached out to me asking if when that will be possible. That is possible now. Again, this is designed not to be a competitive thing at all for your practices. We really want patients coming to you, but in order to try to help with some of the mildly symptomatic patients that do need these tests or need a test to be able to return to school, those patients can be referred, and we'll include that information and messaging that goes out today in terms of an email link that families can reach out. And that is it for me. I saw some things going in the chat, but I couldn't read and think and talk at the same time. So I'll look now. Renee, do you have anything?
Nothing for me.
I don't think there was any other major questions in the chat. So any questions or issues that folks have?
Chad, I just want to qualify, Liz Murray put in the chat that post-vaccination guidance is for the 3 days post-vaccination. That is true, Liz, but it still is in direct conflict with the guidance that Monroe County released back. It was like January or March. I can't even think what the date of that guidance was, but that has been in existence for months now. So we do need to clarify that. Sorry. Kim.
Oh, I was just going to just make a clarification point that there are walk-ins this weekend at all of the county clinics. So if you want to get or just share with your patients that is an option. They're also doing walk-in booster appointments for any adults Sunday at Edgerton Arts Center downtown. So just wanted to put that out there as well.
Perfect. One other thing I should bring up, just because it's good to convey this now. So there has been a lot of discussion with the surging rates of hospitalization. So we are not yet back to where we were January, February of this year, which was our peak of hospitalization with COVID. However, hospitals are more unilaterally full, and largely it is because of lack of nursing home beds for discharge. There's literally hundreds of patients who are on alternative level of care status who are waiting to go to nursing homes, but there are no nursing homes to take them. And largely this is because of a staffing issue in the nursing homes. So more and more we are seeing concerns about our ability to do elective procedures, especially elective procedures that require post-op hospitalization. So folks have asked and reached out. So one, yes, the EDs are packed. It's every facility. There is really no facility in the entire Finger Lakes or Western New York region. I can tell you that as of last Friday, the closest ICU bed was in Albany or Northern Pennsylvania. And to get a patient transferred was usually going to a general floor bed, was usually going a couple hours out of the general region. And ambulance crews just couldn't sacrifice a team to send somebody that far out. So patients have been kind of loading up in the EDs. As far as our elective procedures canceled, as of right now, my understanding this is true for Rochester Regional as well as all of the U of R facilities. Any elective procedure that requires a post-op hospitalization is being reviewed and risk stratified. So if it's someone, if it's a cancer procedure or something of that nature, they are doing their darndest to try to get those in. If it is an elective procedure a la joint replacement, those are being pushed out for the time being because the bed space is so sacred and limited at the moment. For ambulatory elective procedures at this moment, those are still going on as planned. There is, as per the most recent executive order from the governor, if a hospital has less than 10% bed capacity, all elective surgical procedures and procedures in general are supposed to be scuttled so that they can reallocate that staff to the hospital. The difficulty is that staff doesn't necessarily always have the most utility in the hospital. They haven't worked in the hospital a long time, so they could be helping hands, but they can't be fully independent. in an ED or even a med surge or certainly an ICU. So what we also saw that from last time is when we delayed things like gallbladders or even colonoscopies, all of a sudden the patient who had, kind of mild cholecystitis was representing floridly septic because of the delay in procedure, or the patient who had a polyp was coming back, with more advanced colon cancer because their colonoscopy got delayed. So we're trying as much as possible to maintain the elective procedures. We do anticipate an update from the governor's office on Friday. The governor so far has not been terribly prescriptive of who and when. The governor's office did release a watch list, which most of the hospitals in the Finger Lakes region were on, where that they could consider demanding that those procedures be curtailed, but that is not happening yet. So this is a very fluid situation. So I know I've had several folks asking more from my noise hat, or can patients get moved there? We've heard that this procedure is going to get curtailed. It's not, if it's a non-admitted elective procedure for right now, things are still moving on, but things could change within a day or so. So definitely we will try to keep you updated, but this is probably the most fluidly changing thing right now in the healthcare marketplace, I would say. So I think that's all the updates. Nothing else in the office. I did see that we're starting to see flu. That has been a concern, that we are kind of starting to see flu more ubiquitously. And the concern is that we may start to see that holiday surge of COVID coinciding with flu surging, and that's going to be a god awful mess. And if Omicron is not a nice sandbox player, that can only make this more difficult. So the next couple of weeks are going to be trying, to say the least. I don't think we have a lot of pop-offs at the moment. Any questions or other issues that folks have? All right, we will reconvene next week. Anything, issues, keep the emails coming. We will try to answer them as best we can. And have a lovely week, and we'll see you next Wednesday. Take care, guys.